Welcome, everyone. This is Patricia from the International Hospital Federation. Thank you for joining us in our webinar, Implementation of Value-Driven Outcomes Program to Identify High Variability in Clinical Outcomes and Costs. This webinar is being presented by Jeff Young, Associate Director of Advanced Analytics and Visualization at the University of Utah Health. Just a few reminders before we proceed to the presentation. All attendees will be on mute throughout the webinar. Please feel free to ask questions during the presentation. You can do so by typing in the questions panel on the right-hand side of your screen. We'll try our best to go through all the questions after Jeff's presentation. The recording of today's webinar will be available at the IHF website next week. We will be sending you the link via email. You can also view previous webinars on the IHF website. I would now like to introduce our webinar presenter this month. Jeff has worked for the University of Utah Health for 5 years in their Decision Support Department and also has a master's degree in economics from the University of Utah. He has worked specifically on analytic tools to highlight variability and opportunity in outcomes of care, as well as utilization of resources. He currently is over the advanced analytics efforts, including operational predictive analytics and efforts to integrate analytics in care providers' workflows. Jeff, I am handing it over to you now to start your presentation.
Oh, hi, everyone. Thank you very much, Patricia, for the introduction. So good morning to everyone, or I guess at least it's good morning to me here in Salt Lake City. It's 8 in the morning. So good afternoon or good night wherever else other people are calling in from. But I'm excited to have this chance to talk about our value-driven outcomes program and how we've gone about identifying high variability between physicians, between units, between locations in their clinical outcomes as well as costs. How we what I'd like to go through is this program, how we went about putting a team together to build these kind of tools that had transparency around cost and outcomes data, and how we've use that to drive quality of care initiatives as well as contain our costs. So here is a quick little view of the University of Utah's campus in Salt Lake City. If any of you haven't made it out there, it's a beautiful place. It's usually pretty green in the summer, and then in the winter, these mountains are covered in snow. It's a great place to ski. But nevertheless, University of Utah Health, going back 6 or 7 years ago when this initiative started, was concerned, like anyone else was concerned, with just the rising cost in care. And kind of costs were going up, payments weren't going up at the same rate, definitely. And so there were these ongoing discussions on how do we contain our costs, or how do we make it so that we can still run a profitable organization so that we can deliver quality care to our patients and all these people living in Salt Lake City. So there were a lot of different solutions that we went through, a lot of different vendor solutions and strategies. This is how you fix healthcare. These are the hidden costs, et cetera, et cetera. I'm sure everyone on the webinar is very familiar with articles like these. So the fundamental problem that we decided the way we wanted to tackle this was kind of based on this Kaplan and Porter New York Times opinion piece that essentially said hospital systems don't understand the cost of delivering care. And if they could understand these costs, then they could, identify variability in costs, and it would transparency around the cost of care would give the users kind of the ability to, drive where their organization was going. So a little bit about our history of cost accounting and how we've maintained our costs. So prior to 2007, we used a vendor system where I don't know if people are familiar with these. You do these manually updated RVUs and you get an average cost for every different procedure you do. So you get an average cost for what it costs to do a joint replacement, average cost for an outpatient visit, et cetera, et cetera. So what this doesn't have is any of the kind of case-by-case variation that's really meaningful to drive change. So we built an internal system in 2007 on our data warehouse where we tried to identify, visit level data that was available that really drove utilization. And from there, we built our value-driven outcomes tool, which we're going to look at. We'll look at these cost reports as well as bring in the outcomes piece. But this is full costing, allocating every GL expense to actual utilization. So how long was a patient on a unit? What was every supply that a patient used? How much did those supplies cost us? And then, doing this internally gave us a lot of flexibility to really engage with the operational side around saying, well, for your unit, what's the best, most meaningful way we can allocate the money that gets spent to the patients that are using that money? So this was kind of kicked off in May 2012 by our senior leadership, who put a team together of data warehousing resources, analysts to do visualization, as well as some providers who kind of could guide a lot of this work. And the objective was really to establish an analytical foundation for understanding and improving care value. So value being the cost to the institution as well as the quality. So we needed data around this so that we weren't just making, anecdotal decisions. So it was resourced and managed as a top institutional priority, which is important because a lot of analytic initiatives like this, they really need senior leadership support continually to really drive getting to a point where you can make actionable, where the data is actionable and where you can make real decisions. So the expectations was they would want to see a prototype in 3 months and an operational system in 6 months. So very ambitious, but they resourced it and kind of provided the members of that team all the time they needed, kind of setting aside some other duties to get this done. So a little overview of really what the data foundation looks like is we've got all our clinical data sources, our EMR, all these different source systems that track everything from vitals, from everything that happens on a patient encounter. And we've also got these financial data sources, our general ledger, our procurement system where we buy all our supplies, different programs like that. So we've got all these data marts sitting in our enterprise data warehouse. And then what we do is we combine these two data sets where we allocate all the financial data based on the clinical information we have, based on all these algorithms and rules that we've created. And then at an encounter level, we can see all the line item detail of the cost. This is where we also bring in all the outcomes data that we have. So for an encounter, we can see for one visit, we can see all the cost allocations, and we can see all of their quality information. And then upon this big integrated data system, we built all these reports and all these dashboards where you can really, and we'll look at a lot of those where we've really tried to show this is the variability in cost and outcomes throughout our system. So a little bit of an example of what this kind of allocating these costs look like. If anyone's, everyone on the call probably is familiar with how much goes into care. So this is an example of an emergency appendectomy. So this patient came in on day 1 through our emergency department. They ended up having surgery. They ended up in a surgical ICU unit, and then an intermediate unit, and then a step down unit. So they were here 3 days from the time they came in to the time they left. While they were here, on all these different units, they utilized supplies, imaging, medication, labs, other services. There was labor expense for all of the nurses and techs and doctors. So the goal we really had is that if you take all of those things, if we can track down each of those things and sum them together, we can know that's the total cost of providing patient care for this one patient who had this emergency appendectomy. So when we sum all of those things up into the buckets, we get all of these different areas touch this one patient, right? You got anesthesiology, the OR, imaging groups, lab groups, all these different groups played a part in the care of this patient. And so when we look at these allocations on the professional side, we've got an anesthesiologist, a neurologist, a pathologist, radiologist, and the surgeon. So for this one appendectomy patient, we have all these cost allocations, and then, you know, due to this VDO transparency algorithm and kind of costing rules, we can allocate all of these costs. So for each visit we have, for example, this visit, we can look in and know exactly, okay, this is what it cost us to deliver care on the facility side as well as on the professional side. And we can look at all the costs that got allocated from each of these orgs, and then we can see, you know, what's our supply cost when we do emergency appendectomies? What's our lab cost on average? What's our lab cost for provider A versus provider B? But to be able to do all those things, I just want to show you've got to be able to allocate all of these costs and all of these outcomes down at the most granular level. So then you have that analytic kind of capability to slice and dice the data however you like. So when we allocate the costs, for our hospital system, we have 4 hospitals, 10 community clinics. We see over 30,000 discharges a year and over 1.5 million ambulatory visits a year. So we allocate we do this same allocation to all of these visits. Every single visit is going to get the same automated allocation of all our nurse labor is going to be allocated to visits, all of our supply costs, etc. So then I'll try and give you an idea of kind of some of the reports that we've built off of this information. So the first report that I'd like to show where we've seen some real value that has driven some change in behavior and performance has been this provider comparison. So these reports, for example, what we're looking at is 6 providers who perform the same cost. This is a total knee replacement. And we can look at these different colors represent these different buckets. So supply cost, facility utilization cost, etc. So we can look at stuff like, okay, let's look at total knee replacement. We know we have 6 docs that do it. We look at it and we can say, whoa, now why is, you know, doctor number 4 so much more expensive than the other doctors? And down below we can look at their volume. Well, it turns out doctor number 4 in this case only did a couple of these, and he did them at our oncology hospital. So we probably want to exclude him from this comparison. And so that kind of leads to the next point is, you know, I'm sure anyone who's really worked with doctors looking at these things, you look at a comparison and the doctors say, you know, well, I've got the sicker patient, so of course I'm going to be more expensive. So since that would be the kind of response from all of these doctors probably, we tried to build in some risk stratification, comorbidity, information, acuity information like that, so that we could control for those things, so that we could say, well, you know, controlling for some acuity and comorbidities, actually, you know, you are a little more expensive. And then more meaningful than being more or less expensive is we can drill into why they're more expensive. So on the supply side, we could drill into individual cases. So these are all the individual cases for a provider that make up that average. And it could be that a couple outliers are driving the difference in cost. But we could also look into, here's what supply you use, here's what supply someone else uses. So one of our initial first, big cost savings wins with VDO was using the tool and identifying that for joint replacements we had providers using different brands of knee replacements that had vastly different costs, and they were unaware of it, and to a large extent we were unaware of it as well. And we use this information to standardize the process and save a lot of money as a result. So this can kind of show us how we can drill into that detailed cost information. So like I said, we look at supplies and we see, oh, someone's more expensive than other people. So we drill into, we can pick facility utilization, and we can drill into, who has longer lengths of stay and therefore is utilizing more labor costs, or imaging, who's ordering more of what scans than other people. And the great thing about this information, we can do the same on all of these. The great thing about this information is, we found that the doctors are very collaborative. They're very engaged in improvement efforts, but they really don't have a lot of time. And so good data that really is actionable can drive these conversations where we could sit down, and we did sit down. We had a group with a quality improvement specialist, me, a value engineer. We sit down with the joint docs. We share some of this information around, here's who's overutilizing labs. Here's the different supplies that are going on. And we were able to really let them talk through a standardized process. Well, we should all be doing this. We should be doing this. We shouldn't be doing this. And then on our side, we could build data rules around that and track how well they were doing. And we'll get into more of that in a couple slides. So in our institution, I'm sure a lot of you have probably seen this the value equation is what it's called. But essentially on all these projects, anything we do, we have to take into account not only the cost, but its effect on quality, and vice versa, and service, which we measure by our exceptional patient experience. So how is the patient experiencing their care? What are the quality metrics? And then what is the cost of care? So getting into a little more of the data structure, we've really tried to build a semantic data layer that lets anyone in the institution query and have access to data. Our main takeaway over our time has really been transparency. We're trying to build transparency around data and a culture of kind of getting together to look at data to decide what's the best course of action. And to do that, you've really got to make an investment and to have quality data that people can access. So we have this clinical universe. Universe is a term that's specific to the tool, the business intelligence tool we use. But within it, people can query patient information, encounter information. So where were they seen? What happened when they were seen, etc. Orders, specialty data. This is a lot of stuff that we've built, that our data warehouse has built specifically for certain groups. Outcomes data. So all the outcomes data that we track. We also do patient-reported outcomes at a lot of our clinics, where we will hand people an iPad when they show up and they'll take a quick survey. We've got a lot of different data like that. So the great thing is all this data is in one place, where, in a drag and drop environment, where a provider can come in here, any group that's interested in their data has the ability to take a look at it and kind of dig in and maybe answer some of their own questions, or typically when people are engaged with data, as you guys know, it just lends itself to more and more questions, which is great. So from there, from the initial reports, we did find that we put so much information in them that you know, a provider who doesn't have a lot of time really can't just go dig and dig and dig through data. So we've tried to build more and more reports that really identify opportunity kind of within a click. So, you know, 1 click, 2 click, you can really get at some variation. So this is a value explorer that we use currently, where a provider can get in. It'll show all of their cases, and as they click on different cases, it'll show how they compare with their peers on cost, length of stay, 30-day readmission rate, etc. So if I'm a doctor, I can get in here, click through these, and it'll show how I compare in cost. Am I less expensive on average, more expensive? And then it'll show what that variation's driven by. So if I'm 10% more expensive on this graph on the middle right, I can look and say, well, I'm 10% more expensive because I seem to be utilizing more labs and supplies than my peers. And then they can drill in and really look at the detail of what do I use that other people don't use, and what do they use that I don't use. So, and some of this is just going to be preference. Doctors use different things because they may have learned to do it a different way, or they have preference. But also it can also, I've been a part of a lot of these projects, and there always is a fair amount of sticker shock when you can get to this data, and you get a lot of doctors saying, oh, I had no idea this was that expensive, and I had no idea, you know, I use 2 of these every time. I think I could get by with 1, or maybe there's, you know, it's really, I didn't know it was so expensive. Maybe there's another, you know, something else I could use instead that's half the price. So we've done the same thing around ambulatory surgery, inpatient surgery, essentially anything that we can do a meaningful comparison. We've tried to build these and train doctors and give them access and kind of make it as easy as possible for them. So this kind of leads us to this idea that around more on the quality side of things, where we have come up with this idea of perfect care. So perfect care started with our joint replacement project, where the joint replacement doctors essentially said, here are 5 or 6 things that we want to happen every time someone has a joint replacement. So some of them were kind of efficiency metrics, some were quality outcomes. So we don't want them to be readmitted, we don't want them to come back to an ED within 90 days, but also we want them to have a PT consult the same day. We want them to be, you know, discharged into this unit. So they came up with 5 or 6 things that were meaningful for them. And then we built out a scorecard and some reports where every month we would just email them this scorecard, and it would show their progress. And they could see in the kind of the composite score of if they did all those things correctly, it was called perfect care. And we saw right off the bat that cases that had perfect care ended up being significantly less expensive than cases that didn't have perfect care. When they didn't get the PT consult, they stayed longer and it was more expensive. When they didn't go to the right unit, they stayed longer. You know, some of those things are kind of out of their control, like sometimes a patient got readmitted because they fell, or things like that happen. But the important thing was we could track it monthly, and then when one of those looked like it needed attention, we could give it attention. It was kind of in the monitoring phase. So along with those, a few more examples, just cost reports where we've built out that just highlight variation and highlight kind of trending. What can get lost in some of those older reports is, yes, I'm more expensive, but what does the trend look like? Am I getting less expensive? And so we built out some reports that do those things, that trend over time and look at costs a few different ways. Same with the detailed costs. These are really popular, especially looking at individual cases and looking at why these 5 or 6 cases on the far left were so much more expensive than the other cases, or looking, what did my diabetic population look like? What does this population look like? That granularity of data really lets you be flexible with, what you can do on the analytics side. And also for some groups, I mean, a lot of what we looked at is very episodic, like a joint replacement. You essentially are doing the same surgery, but a lot of populations aren't like that. So for example, for CV heart failure patients, it's a longitudinal kind of care program. So we tried to build other reports where you could click on patients and you could see their care over a long period of time. So in this report, you click on a patient in the bottom left and it shows all of their visits, where they went, did they go, was this an ED visit or a clinic visit? How much did it cost? So it really was a popular way for this group to kind of click through, and they could track their patients over time and see, like, when they're not coming to see me, where are they going and what services are they having done? And then some drill throughs where they could see things like, okay, what are all their vitals look like? What do all their, their demographic and history look like? So I talked about the scorecard we did for joint replacement, and that kind of kicked off this initiative of doing these video value projects for all these different groups, where we could engage the doctors and engage the care team that was involved there, and kind of say, okay, let's identify and define a population, and we'll track their costs, and also tell us what are the most meaningful outcomes for this population, and we'll build those out for you in a scorecard, and then we can track it and we can track your interventions. And these have been really, really popular because they're targeted to, they can be really targeted and customized to these specific groups. So what's important to joint replacement is not important to, elective inductions for, moms giving birth. So initially we built out some, universal scorecards, but you put something like death on one, well, that's relevant for heart failure. It's not relevant for most other conditions. So one by one, we've gone through and built out these monthly scorecards. This is what a few of them look like. And they've been really popular because we can do the initial work, and then we can send them out every month, and they can track all these different quality, efficiency metrics and their cost. And then when is needed, we can dig into, okay, why are we doing worse at this, or why is our pharmacy cost going up? It's really been a great system to monitor the quality of care and performance for some of these groups. So quickly, because I want to leave some time for questions or discussions, we've gone into a few more even specific groups like OR costs, where we will look at a procedure. For example, this is laparoscopic repair inguinal hernia. So this is every provider that does this same procedure, and we built reports around that. And that's really been able to show us cost difference in, surgeons that do different techniques, and the cost difference associated with these different supplies and different techniques. It's interesting. So this is one of the first procedures we looked at when these reports were built, and it turned out, 4 of these providers who were doing this were using a supply that was supposed to be a time saver, and it made them significantly more expensive than another provider who was really high volume. But consequently, the other provider who wasn't using the time-saving supply was significantly faster doing the procedure, as well as being less expensive. So that's something these surgeons, kind of working in their own silos, had no idea of, and the data spurred the conversation where they talked about, like, oh, what's the appropriate way to do this? what do our outcomes look like? If our outcomes are similar, we should be doing the procedure. There's no reason to use this time-saving device. And it turned out they did make some changes, and a few of the providers who only did a couple of these, they came to the conclusion, I should hand these patients off to someone else, and I can focus on these procedures. And when I do a couple of these, they're expensive. It's not efficient. So we also burst out this same data where every month our surgeons get reports that show all the cases they did, the cost of that case, as well as a comparison to themselves over the last 12 months in their department. And we've done the same thing around lab utilization with some groups where every week they get a report that just shows these are the labs you utilized, these are the labs your peers utilized. And this group was interested in doing this because, as an academic hospital system, we've got a lot of residents and students learning, and they kind of anecdotally thought, well, it seems like the residents just order all these labs because they don't want the doctor to show up and yell at them for not ordering something. So as a result, I'm going to order everything. And they really wanted to change that culture to one of, why am I ordering this? Is this necessary to kind of eliminate the waste? So I'll kind of close with this. We came up with this program called UP, but it's this healthcare partners program where if providers identify cost savings projects, we kind of created a group that's a mechanism by which they can come, show what they're planning to do, and of the cost savings they experience over the next year. So we're going to do this differently. It's going to save the hospital this much money. We'll measure how much money it does save, and then share some of those savings with their department, and they can use that money for research, travel to conferences, etc. And this is just a list, an old list of some of these projects that we've done, as well as what their department got paid. So I think we're making progress. We've had some articles written about us. I presented this a few places. We're continually trying to build more transparency around the data. We're continually trying to find other ways to engage providers, engage nurses, to kind of continually work on this that will be ongoing. So that's all I have. I guess we can now get to if there's any questions people have or discussion.
Thanks, Jeff. Very impressive program. So we'll start reading some questions from the audience shortly. Just a reminder to everyone, you can send your questions by typing them in the questions panel on your screen and click send. Before we proceed to the questions from the audience, Jeff, I have a few questions. So what would you say is the biggest obstacle to rolling out a program like this?
I'd say the biggest obstacle we had was engagement. And I feel like we have engaged providers, but I do think you need your senior leadership to be pushing these programs. Our providers, they do clinical work, and they do research, they teach. To have a time after all of those things are done to also kind of engage in some of these projects can be difficult. And so our senior leadership kind of created this program where they, for each department, created these chief value officers. So each department essentially had someone that they bought. Our system bought some of their time for them with the expectation you need to engage in these projects. So that kind of shows the investment we've made in some of these things, but the response from them has been great. I just think you got to kind of have clear expectations about people's incentives and how much time they're going to have to engage in some of this work.
Thanks, Jeff. So what advice would you give a system just starting out on this journey of understanding costs?
I would say on the technical side, I imagine a lot of places have very talented technical resources, people there who could do some of this stuff. It's just kind of organizing them correctly and giving them access, making sure they have the access to all the necessary data, and then being really, really clear about this is what we want to get to initially. And even for us, it's an iterative step-by-step process. So I don't think you can have the expectation that we're gonna all of a sudden get to a mature level, but I think you can set goals that, okay, wherever we are, this is the first place we need to get to. First place we need to get to is, allocating all of our cost of visits, and then we can look at that. I think just finding internal resources that are talented and can do this kind of stuff, and then let it kind of organizing them and allowing them to be successful.
Great, thanks, Jeff. So we have a question from Chris. He's asking, what investment did your organization make in headcount and IT systems to build this capability?
So we did, as far as systems, we did invest in a web intelligence tool, SAP Web Intelligence, and we also use Tableau now, where a lot of the reports reside. From an IT perspective, we didn't add FTEs, we didn't add people. We already had a pretty mature data warehouse, and there definitely was an opportunity cost because a group of people from data warehouse, from the team I'm on, decision support, a couple other people were kind of sequestered to only work on this for a few months. So as a result, other things that would have got done didn't get done. But from an institutional perspective, we didn't want to add a lot of FTEs. We just wanted to say, you know what, this is really where we're going to focus these resources, and this is their priority. And that worked for us. But the initial team probably had 8 to 10 people who worked on this, between half and full time for at least an initial 3 months.
Thanks, Jeff. Chris is also asking, are you able to incorporate post-discharge care costs and outcomes from providers outside of your organization, such as home health agencies or SNF providers?
So yes, when we have we do have some data sharing agreements with some home health agencies. Basically any data we can get our hands on, we will incorporate. Some of these groups use registry data. Our joint replacement has people making phone calls to collect data 30, 60, 90 days post-discharge. So we do have some agreements. That being said, we give people kind of a suggestion where to go post-discharge as far as home health, but skilled nursing facility, but they ultimately decide where they go. So a lot of times they end up in systems that are, aren't really in our network, and we aren't going to collect any data back unless we call them and do it ourselves, and that only happens for a few use cases.
All right. We have a question here from Fergal. How are supplies that are used during procedures captured? Are you scanning barcodes? If so, are they standardized barcodes such as GS1, or are you labeling the items in your hospital and then scanning proprietary in-house barcodes?
That's a good question, because a little bit of background. Initially, we used our charge information, but we only charge for supplies that cost over $50, and the rest of that is just grouped into the room charge, but we wanted to get everything. So we do use a scanned barcode system. I honestly can't tell you if it's proprietary. I don't think it is. I think we're using a generalized system from our procurement where we track, and that's how we track everything. And then we map that back to the cost we paid for each of those items. So if it scanned that we used a 50-cent piece of, gauze on a case, when we look in the tool, we're going to see, one 50-cent piece of gauze was used. We do map to a few standardized, like for lab supplies, medications, hierarchies, so that we can, have some kind of drillable path, or so that we can group like supplies.
Thanks, Chef. We have one more question here. What EHR system are you currently using?
So we use Epic.
Daphne is asking, when you started with the project, what did you do to encourage doctors to be involved in the building of standards of care?
So we've used a few things. We have this CVO program. Some groups are very engaged because essentially their department head has kind of said, every group is going to be engaged in a quality improvement project, and this would count. Other groups have been engaged because of the UP project, but also as researchers in an academic system, this is appealed to a lot of them, because we will allow them to use this cost quality information to publish. And I think we've had over 20 to 25 different groups use this data to publish papers around like the cost savings implications. So a lot of those different things. We also provide the resources readily. If they've got a project, we will provide a quality consultant, an analyst, the data warehouse support to build out what they need. And really, the senior leadership from the top down has really pushed. We as a system will be engaged with these projects, and that has, really motivates and encourages people to engage.
Great, thanks, Jeff. Carlos is asking, are your platforms commercially available? He's asking, in other words, can we take them to our hospitals?
Yeah, I mean, potentially. We've had discussions with a few groups, and we've had some calls, and we've kind of technically walked through this with different groups. We haven't made any big commercial investment, but I mean, if someone was interested in kind of exploring more of this for their system, feel free to reach out to me, and we can definitely discuss that.
Thanks, Jeff. Okay, if there are any more questions, please type them in the questions panel. So Daphne is asking again, isn't then incentives the only way that they can encourage involvement? Because they're a funder and they've started with provider engagements to encourage standards of care, but find a lot of resistance from doctors as these was viewed as interference. So any other suggestions to encourage the involvement of the doctors?
Yeah, I mean, I think that's a good point, and I think we've definitely found that in pockets, that maybe you build stuff and you're really excited, and then you show up and it's kind of, some people like the status quo. So I think what we have tried to do from the get-go is really make it a partnership. And I know this won't always work, but we really try and let them drive the work that's done. We don't try and show up with a finished product and say, this is what we have. We really try and sit down with them initially and kind of say, well, what metrics are important to you that we could show you regularly, or how can we map this out? And I mean, we really have found that doctors, I mean, they want to deliver quality care, and they're cognizant of the fact that for them to deliver quality care, a hospital has to have the financial strength. So we've tried to just partner with them provide opportunities for them to get a lot of credit, or for them to be able to publish research on what we do. And, like I said, we've tried to make financial incentives, or their leaders have tried to create a kind of either incentives or an expectation that there will be engagement and they will be required. I mean, these projects that are ongoing, the providers are required to go regularly, every 6 months, every year, and report back to senior leadership on how the project is going. So that definitely puts some urgency into not go and have nothing to show for yourself as well. Sorry, Daphne. I hope some of that helps, but I think we experience some of the same issues.
All right, thanks, Jeff. So there are no more questions. If any of the audience thinks of additional questions later on, you can contact Jeff directly. His email address is on the screen right now. So before we end the webinar, Jeff, is there anything else you want to say or share with our audience?
I just want to say thanks to everyone for participating. I mean, if you want to reach out, I would love to hear what other people are doing at their institutions, because we're constantly trying to learn from ourselves and from what others are doing. And I think it's an iterative process, and some of the things we've done well and figured out, and some things we're still continually trying to learn. But we're really just we've seen great gains financially from outcomes, and just culturally, by really pushing data transparency and transparency around some of this cost information where appropriate. I know it can be very sensitive information in some instances, but just thank you. Thanks for the opportunity to share a little of what we're doing.
Thank you, Jeff. We appreciate the time you allotted to share about the Value-Driven Outcomes program. It's definitely an impressive program. I would like to thank everyone as well for joining the webinar today. We will be posting the video recording of this webinar on the IHF website. You will receive the link via email sometime next week. We hope you can join us again in our future webinars. IHF will be sending more details about that soon. So thanks again to everyone for attending the webinar, and I hope you all have a great day. Thanks.